My name's Alex Shadenberg. I'm the Executive Director of the Euthanasia Prevention Coalition, and I have been involved in this work full-time since 1999. In fact, I've been doing this a little bit longer than that. For those who don't realize that I am a Canadian, don't hold it against me. That just means I live north of the border. That's all it means. I'm here with Sara Buscher, and she'll mention a little bit about herself. So Sara, could you mention a little bit about yourself?
Sure. I'm a retired attorney and CPA. I have spent probably all of my professional life advocating for and assisting and helping older folks and people with disabilities. And that's why I spend my passion. And that is why I am involved with the Euthanasia Prevention Coalition in the United States.
So I'd like to say right off the bat that I'd like to thank Crystal from the Diocese of Salt Lake City, who have co-sponsored this event. This is a second event we've put on with the Diocese of Salt Lake City, so this is very good. And I'd like to also thank all those who have promoted this event, because quite a few groups have sent out promotion of this event. So first of all, the topic, as you see here. So Sara, would you like to begin?
Certainly. So the first thing we want to share with you is the AMA's definition of physician-assisted suicide, because when we talk about legalizing assisted suicide, that's what we're talking about. And it occurs when a physician facilitates a person's death by providing the necessary means or information that would enable that person to perform the life-ending act. For example, a physician provides sleeping pills and information about the lethal dose, aware that the patient may commit suicide. Now, in their opinion, the AMA said it's understandable but tragic that some people in duress may come to decide that death is preferable to life, but that allowing physicians to participate in assisted suicide would do more harm than good. Physician-assisted suicide is fundamentally incompatible with the physician's role as a healer and would be difficult or impossible to control and would pose serious societal risks.
Now, I wanted to make a quick comment because there are some people who are part of this presentation, who are attending this presentation, who are from outside of the US. And you might have noticed that the British Medical Association recently changed its position on assisted suicide and went to neutral. So as it is right now, the American Medical Association is obviously not neutral on assisted suicide.
Right. We had a kind of they were flirting with going neutral about 4 years ago, but they did not.
I should make another comment that in Canada, we were always opposed to, the Canadian Medical Association was always opposed to euthanasia and assisted suicide. And when the court cases were coming through that actually in the end legalized euthanasia in Canada, the Canadian Medical Association at first did not change their position. What they did is they said that a physician could, with their conscience, choose to participate in the law or choose not to participate in the law. So that's how they changed it. So instead of going with the contentious way of changing their position, they just said a physician could conscientiously object to the law or participate in the law, which of course opened things wide open. And that was their little opening that they made in order to go wide open as they have in Canada today. So go ahead, Sara.
Sure. So I want to kind of just give you an overview of what's currently happening now. So we have 10 jurisdictions where assisted suicide is legal. That means it's not a part of the homicide statute anymore. And those states are California, Colorado, Hawaii, Maine, New Jersey, New Mexico, which we added just this past January, Oregon, Vermont, Washington State, and the District of Columbia. And then in addition, in Montana, it's permitted based on the Baxter court decision that created a defense of consent.
Yeah, so what that would mean is that it's technically illegal in Montana, but a physician, if prosecuted, could claim that the patient had consented.
Right. Of course, if they're dead, they're not available to testify. So
That's right.
I don't know how much comfort that provides to a physician. So we had 9 bills that were introduced or debated this year that have already died, and we list the states up there where that's the case. Arizona, Connecticut, there was quite a fight in Connecticut, but they did not prevail. Indiana, Iowa, Kansas, Kentucky, Nevada, North Dakota, Rhode Island, all of those bills are dead. As I said earlier, we had one that was enacted in New Mexico. And we have one that's currently active in Massachusetts. They just had a big all-day hearing in their joint public health care committee. And so we're kind of waiting to see what direction that's going to go. There are a lot of people working against it on the ground in Massachusetts. And then we have 4 that are in states where their legislature is in recess right now, and they'll come back in January, and these bills are then going to still be potentially acted on in 2022. And those are in Delaware, Minnesota, New York, and Pennsylvania. Four states where there's bills to actually expand or loosen their current assisted suicide laws. Some of it's by adding, like, physician assistants can do it, or making it just easier to get approved for it. And those are in California, Hawaii, Vermont, and Washington State. And the California bill was just recently signed into law, and it reduces safeguards and permits 2 requests within 48 hours for a lethal dose. And it actually, which I find just kind of mind-boggling, it says that if the person makes a request to a physician who refuses to participate in assisted suicide, and that physician then, transfers them or recommends they go somewhere else, and they find one that will do it, that request that they made to the doctor who won't do it counts as one of the 2 requests. And then, and the other 3 bills, as I said, carry over to next year. We had 3 states where bills were introduced to strengthen penalties for assisted suicide or prohibit it. And those were in Montana, Pennsylvania, and New York. The Montana bill would have overridden the Baxter decision. And it died on a tie vote in their Senate. So we will definitely see that one coming back. They just needed, one more vote, and they could have passed it.
And the governor of Montana was supporting the bill too. So if it had passed in the Senate, it would have been signed. So.
Right.
Yeah.
Thanks, Alex. The one in Pennsylvania was just signed into law on September 30th, and that one increased the penalties for assisting a suicide if the victim is intellectually disabled. And the New York bill remains pending, and that carries over also to next year. So we will have 2 bills in New York. One's to legalize and one to make it stronger. We've got 3 court cases that we're watching, and some we plan to participate in as a friend of the court when they get to a briefing stage. The first one in California, the Shadenberg case, seeks to allow active euthanasia for people who are unable to self-administer the lethal drugs. So they had 2 plaintiffs, one with multiple sclerosis, one with ALS, who are saying, I'm enjoying my life now. I don't want to go before I lose all my abilities. But when I do, I won't be able to self-administer.
Now, one of those
And
California complainants has died already, but yes, go on.
right, in fact, we don't know for a fact that that person died of assisted suicide, but it seems likely because they petitioned the court for an emergency injunction that would have allowed the act of euthanasia. And the basis for the emergency was that that individual was planning to use assisted suicide to die on September 21st, which she did die on September 21st, after the court denied the petition on September 20th.
So I think at this point, it's a good idea to distinguish between assisted suicide and euthanasia, because euthanasia is what is basically happening in Canada. And how euthanasia is done is the physician, or in Canada's case, also nurse practitioners, can then lethally inject. So it's done by a lethal injection. It's done by a syringe, and there's a 3-drug administration, but it's a lethal injection. Whereas assisted suicide uses the same sort of drug cocktail, but the person technically has to self-administer. So when you're looking at the California court case, the idea in that case is that assisted suicide discriminates against someone who's incapable of self-administering. So assisted suicide then, because you self-administer technically, obviously it could be done other ways, but this is the technicality of the law, that is a form of suicide, whereas euthanasia is a form of homicide, because in the case of euthanasia, it's an injection, right? Look, that's how it's done, by injection. Go on, sorry, Sarah.
No, that's fine. The next case, and I'm not sure how to pronounce this man's name, so I'm just gonna do my thing and say Gideon say. A doctor in Portland, Oregon, wants to have the residency requirement in their assisted suicide law declared unconstitutional. And so this was just filed in the Oregon District Court in Portland. And he's saying he's on the border of the state of Washington. He has patients from the state of Washington who want to die by assisted suicide, and he can't help them because he's not licensed to practice in the state of Washington. I believe that the constitutional basis they're using in their complaint is very, very weak and unlikely to prevail. And in fact, especially in light of the fact that the US Supreme Court some years ago said there is no right to assisted suicide or right to, no right to assisted suicide under the Due Process Clause, which incorporates the legal basis they're trying for in this case, or the Equal Protection Clause of the 14th Amendment. So that's out there. But I guess on the other hand, if this were to succeed, then, and if we had telehealth nationwide, we could have doctors in states that legalize assisted suicide providing the prescriptions and, with online pharmacies getting them filled nationwide.
So this case has got a bit of a funny thing to it, because as the physician is saying, it's someone in Washington state that he would like to do assisted suicide for, and it is legal in Washington state. But remember, if they were to win the case, it's not specific to Washington state. It'd be specific to the residency requirement, meaning that somebody who lives in Florida, where assisted suicide is illegal, they could then have assisted suicide through Oregon, making us Oregon the assisted suicide tourist capital of the U.S. That's what would be in effect the end result.
Now, Alex, correct me if I'm wrong, but don't the Hawaii and New Mexico laws already kind of provide for non-residents to be able to get assisted suicide through those states?
Sadly, New Mexico's law does not have a residency requirement. And that's why when I was fighting, and people who follow my materials that I send out, and I was fighting this telehealth provision idea that was being promoted, I recognized that New Mexico could become then the telehealth assisted suicide capital of America. Yes.
So we were able to work with some congressional staff to alert pro-life legislators that the telehealth bill they were looking at didn't have any restrictions on it for pro-life issues, including assisted suicide. And so that's kind of stalled. But in the meantime, they just issued this federal HHS, Center for Medicare and Medicaid Services, just issued their annual regulation on physician reimbursement, and they extended the COVID telehealth provisions for another year. So
Right.
they're kind of doing it by regulation.
Yeah.
Okay.
And continue on Minnesota.
Yeah, that's exactly where I was going next. So we have a case in Minnesota where the Final Exit Network is asking a federal district court to overrule the Minnesota Supreme Court's decision on assisted suicide. So there was a challenge in the Minnesota courts that the assisted suicide criminal law they had infringed on freedom of speech because it reached talking about assisted suicide. And the Minnesota Supreme Court did strike down parts of their statute, but left parts of it. So if you're talking to another person about assisted suicide in general, that's not a crime. But if you're providing instructions on how to commit assisted suicide, then you're providing the means to facilitate the person's death, and it's still a criminal act. So Final Exit Network previously went to the same federal court and asked them to overrule the same Minnesota Supreme Court decision and lost. So now they've got some new people and some new conversations, so they're trying again. And I'm going to predict that they're going to lose again and maybe even get some kind of sanction and fine for bothering the court so much about the same issue over and over again. So, you know, the courts have maintained there's no right to assisted suicide. That hasn't changed, but they're finding other ways to create loopholes. So, Alex, I think I turn it over to you now.
That's right. Now, some of this has changed thanks to, sadly, because of the New Mexico assisted suicide law, which I will talk about. And it's a serious problem, this New Mexico law, but nonetheless, it did pass. And the question is, how do most of these assisted suicide laws work? And I think it's important because a lot of people, you know, they think in theory of the law, what does it mean? What is assisted suicide? And they're thinking in theory. And we always say, the question is, how does the law work? That is the key to the whole issue, because of course, the problem is that these laws are not what they say they are. But anyway, how the law tends to work is that a person must request a lethal dose. Okay, well, that is supposedly the my body, my choice part of it. It's the request. There's many reasons you might request that you have your life ended. You might be very depressed. You might be going through a significant emotional, psychological time. You might feel that your life has lost purpose or value, and now you're requesting the lethal dose because you have a medical condition that you feel will qualify under the law. However, that may or may not be defined. So there's nothing new about this sort of idea. We've always had suicide and suicidal ideation, and there's nothing good about suicide. The point of it is the law requests that you make a request. But the fact is that the law is not about the request. The law is about how it works for the doctor. These laws are all designed around what the doctor or nurse practitioner must do to cause your death. That's how the law is designed. It makes total sense how the law actually works, even though it's not what the other side says it is. They say it's about autonomy. It's not. It's about the control physicians and nurse practitioners have over causing patient's death. So the doctor must examine, the first doctor, and they have different terms for them in different states. The first doctor must examine the person to determine if that person qualifies. A second doctor must ensure that the prognosis and decision of the first doctor is correct. So I don't know of any state that specifically requires that the second doctor actually meet with the first doctor. I mean, actually meet with the patient. But the fact is, in most of these laws, there was no requirement that the second physician actually meet with the patient. That doesn't mean it never happens. I'm just saying there's no actual requirement. They're actually approving what the first doctor said. This is a very important point if you think about misdiagnosis also. Someone has a medical misdiagnosis. The second physician, if they've never seen the patient, will never be able to catch the fact that there seems to be a medical misdiagnosis here. The person must pick up the lethal dose from the pharmacy. So what you have is once it's prescribed, you're having, and then at this point, once the lethal dose is picked up, now in some states, they're talking about it being sent to them or someone else picking it up, and they have all these other rules around that. But once that lethal dose is prescribed, there's no further oversight of the law, meaning the physician's not going to be there at the death. Only in very few cases is the physician actually there at the death. On top of it, there's no requirement of that. There's no requirement of third-party oversight, meaning some independent person ensuring that the law is being properly followed. All it is once that lethal dose is obtained from the pharmacy, someone is, if they die, is no oversight over that. So the situation is pretty wide open. There was a case actually in Washington State where you had one brother accusing the other brother of causing his father's death. And so there was a lawyer got involved in that case and tried to uncover the truth of that case. And what happened was that because this is all under privacy restrictions, there was no way to figure out if there was any untoward act that happened to that father. So the one brother's accusation could never be in any way challenged in any way, shape, or form, because there was no way to do so. Once the person dies, the physician who wrote the prescription must submit a report. What's crazy about it is you get all these reports, and remember, not all the reports are submitted. If you look at the Oregon data, there's a huge number of reports that are not submitted. No reports submitted. Well, the situation is the physician is rarely at the death, and yet they have to send in the report as to the death of that person. So what is the accuracy of the information? Who is at the death? Often it's the Compassion & Choices volunteers at the death. Who's the Compassion & Choices volunteer? It's the assisted suicide lobby training people to be there to comfort them, to make sure what? They complete the act, right? They complete the act. Mm-hmm. According to the 2020 assisted suicide report from Oregon, there were 245 reported assisted suicide deaths, which was up by 28% from 2019. But in 2020, the ingestion status was unknown in 80 deaths, unknown. So what does the ingestion status mean when it's unknown? Well, it was said in 58 deaths in 2019 it was unknown. What it means is they don't know how that person died. They know that that person received a lethal dose. They know that they died. They just don't know how they died. Now, some of those 80 deaths would be late reports, meaning someone might have died in October or November. And you'll see every year in the reports, they update the previous year's numbers. So for instance, this 245 number that came out in the 2020 report, I guarantee you in the 2021 report, it won't be referring to 245. It'll be saying 248 or 249 or something like that, because there's some late reports that come in, okay? Nonetheless, the ingestion status is unknown in 80 deaths. How do they die? Some of those people died by assisted suicide. Some of them died a natural death. We simply don't know. No report was sent in. We have no idea. And even the department a couple of years ago in the actual Oregon report, they had a line there saying, when the ingestion status is unknown, the cause of death is simply unknown. We just simply don't know, okay? The time of death, yes, go on, Sarah, yes?
Well, I was gonna say, and some of those people might have been murdered.
It's very possible if some of them were murdered. If you consider you've got lethal drugs sitting around. Yeah.
Forced to ingest.
But you wouldn't know. There's no way to know because there's no third-party oversight. And when I say third-party oversight, there's no independent person who does oversight of a death. So we just simply don't know.
Right.
The other thing is, it shouldn't surprise you too much that this is going on in America, because of the fact that when we look at the Dutch data, every 5 years, the Dutch government does a major study, and it shows that between 20 and 23% of all euthanasia deaths are not reported. So if you look at the data, it's actually very similar in Oregon that you're having this 20% rate or so of unreported assisted suicide deaths. We simply don't know. The time of death ranged in 2019 in Oregon from 1 minute. Now, 1 minute, I don't believe. It's not possible someone actually died in 1 minute. They might have gone into a type of a coma quickly or a deep sleep quickly because of the type of drugs they use, but to actually have died in 1 minute, that's hard to believe. To 47 hours. 47 hours, well, that's a long time to die. That's a very long time. The longest time of death in Oregon has been 104 hours. So someone took the lethal drugs. There was a couple cases where people took the lethal drugs and they didn't die. And there's actually a couple stories written about that. 3 people in 2020 were referred for a psychiatric or psychological evaluation. So let's figure this out. Out of 245 known assisted suicide deaths, only 3 of those people were sent for a psychiatric or psychological evaluation. You can't tell me that there's only 3 people out of 245 who are going through deep emotional feelings of hopelessness, depression, so much so that their competency can be questioned. You can't tell me that there's only 3. There's obviously much more than that. In 2019, 1 physician was referred to the Oregon Medical Board for failure to comply with the law, and I did write a little bit about that case. There's actually been 2 in Oregon so far. Washington State assisted suicide data. Now you might notice I've only got the 2018 data here. I think it has something to do with this big debate in Washington State. Now I'm only surmising. Don't say I knew for sure, because I don't. But why have they not been publishing data out of Washington State since 2018? And I think it has something to do with the big push to expand the law in Washington State. That's what I personally think. But nonetheless, in 2018, their numbers increased by 25%. And you see this increases, etc. But once again, in 2018 in Washington State, there was 19 cases where they had no idea. The person received the lethal drugs, they know that, but they have no idea how they died. Now it's only 19. You'd say, well, hey, there was 80 in Oregon in 2020. Absolutely. Nonetheless, it shows you that the problem of possible underreporting of assisted suicide is not an Oregon-only problem. Okay, 19 unknown deaths may be unreported assisted suicide deaths. We simply don't know, but we don't know, and that's the point. And that doesn't make sense. Think about this. You're prescribing lethal drugs to somebody, intentional lethal drugs to somebody, and you don't know how they died. You have no follow-up. You just simply don't know. That doesn't seem to be a very tight, safe law to me in any way, shape, or form. There was also more complications in Washington State in 2018. And so we don't have the 2019 or 2020 data out of Washington State. The report stated that 8 people reportedly experienced complications, which was up from 4 the year before. And it also says 62 people died more than 90 minutes after taking the lethal drugs in 2018. And the range of time from death was 7 minutes to 30 hours. And now, why is that? Why is that? Well, I think it has a lot to do with this lethal drug cocktail experiments that the assisted suicide lobby and their people were involved in. So we're going to go into that right now. Now, why is this issue important? Well, the assisted suicide lobby decided several years ago that they needed a cheaper, effective way to kill. So some of their physicians who were doing assisted suicide got together and they started these experiments. And in March of 2017, the Seattle Times reported that the first seconal alternative turned out to be too harsh, burning patients' mouths and throats, causing them to scream in pain. There was almost 70 of those. There was almost 70 people that died that way. You would think that after a first few cases of assisted suicide using this new experimental lethal drug cocktail, when they're seeing people screaming in pain, you'd say, maybe this isn't working well. No, they kept it going. The second drug mix led to deaths that stretched out hours in some patients, up to 31 hours in one case. So this is all about the drug experiments they were doing and they continue to do.
Now, Alex, just to clarify, they didn't have a clinical trial or volunteers or anything. They're just prescribing this to people that asked for assisted suicide, and those people maybe didn't even know they were getting an experimental drug.
Yeah, so I'm getting into that in a second, but that's exactly it. Yeah, you'll see what I'm going to do with this. But yes, the article published in The Atlantic in January 2019 stated This is what it stated. An advocacy organization called End of Life Washington briefly advised prescribing a drug mixture with the sedative chlorohydrate to about 70 patients. And Robert Wood, the medical director, said, "We know this is going to put you to sleep and we're pretty sure it's going to kill you." Yeah, he told, but it worked with a tragic catch, is what the article says. In a few cases, the chlorohydrate burned people's throats, causing severe pain, just as they expected relief. Does this sound like dying with dignity? Like, let's be brutally honest here. Medical Express reported September 8th, 2020, a little known secret not published by advocates of aid in dying was that while most deaths were speedy, others were very slow. Some lingered for 6 or 9 hours, a few more than 3 days. Assisted suicide is clearly not what it appears to be. So many people support assisted suicide. And this is one important talking point that I think a lot of people keep wanting to avoid because they think it's a little bit touchy, but it is touchy, and that's the whole point. The point of it is people support assisted suicide because they're in fear of a bad death. They're in fear of suffering. And I'm a human being. Guess what? I'm in fear of suffering. I'm sure Sara is not saying, please cause suffering. I'm interested in that. No, none of us are interested in suffering. We're human beings. We don't want to suffer. We understand this. I'm not saying that there isn't anything good about suffering in a sense, but that's a whole other question, isn't it? Many people support assisted suicide based on their fear of dying a bad death. But assisted suicide has been causing a bad death.
Right.
Assisted suicide promoters and practitioners develop these lethal drug cocktails by doing human trials rather than animal trials first. The team appear concerned with the lethal efficacy. Is this able to kill someone? They were considering lethal drug cocktails, knowing that yes, that drug cocktail is very likely to cause your death. Absolutely. And these also were based on cost effectiveness, because they were saying we need a cheap way to do this. It's too expensive, the current formulations. So they wanted a cost-effective lethal drug cocktail as opposed to worrying about the negative consequences of these drugs. Were these human trials done with full consent of the participants? There's no proof that these human trials were done with full consent of the participants. This is an important point for people who claim that it's all about caring, it's all about a death with dignity.
Well,
that's not true.
I don't think there was an institutional review board that
No, there was not.
had oversight and approved this experiment either.
Absolutely. So what the point was is that these people were approved for assisted suicide, and that's true. They've been approved based on their laws. Whether we agree with the law or not is not the issue. The issue is they were approved and they died by assisted suicide, but did they ever consent to being part of a human trial? And the answer to that is probably not. Probably not. And on top of it, if you look at the Nuremberg Code on doing research, these cases were simply outside of the Nuremberg Code. These are actually very unethical acts that were going on in order to develop a cheap drug cocktail to kill. Let's look at what's going on with the expansion of assisted suicide. So Oregon Governor Kate Brown, in July of 2019 signed Bill SB 0579. So what this bill did is it reduced or eliminated the 15-day waiting period. So what it said is that they reduced the waiting period, but if someone was nearing death, meaning they were approaching death sooner, then that 15-day waiting period could be waived. Okay. Now, you could potentially then have a same-day death, is what this bill allowed for. Washington State, and we've already talked about this, that Washington State, Hawaii are debating expansion of assisted suicide. Sara talked about that, and New Mexico's bill was very wide open. So I'm going to talk a little bit about the Washington State very quickly. In 2020, there was Bill HB 2419, which was a research bill to research assisted suicide. The only reason I'm talking about this is not because I like talking about old news, because one of the sections of the bill, Section F, was to examine restrictions based on the requirement that the medications under this chapter be self-administered. So what Washington State was debating is doing research then on assisted suicide and the supposed safeguards. One of those areas they wanted to examine is whether or not Washington State should allow for euthanasia. You don't study something if you're not considering it. Okay. So then last year, this year you have the Washington State HB 1141. This bill didn't pass, but it was very comprehensive. So what they were doing is trying to expand the list of who could participate in assisted suicide. And then what they were doing is changing the word physician to something called qualified medical provider. A qualified medical provider that included a physician, a licensed physician assistant, an osteopathic physician, or advanced registered resident nurse practitioner. Now, why are they doing this? Because they want more people, more medical people involved with assisted suicide, because they've recognized that one of the difficulties with assisted suicide is there's very few people willing to do it. So what do? You expand the list of who can participate in order to gain more assisted suicide practitioners. They also wanted to expand the list of who can legally counsel. Now, this doesn't make sense at all. I already explained that out of 245 assisted suicide deaths in Oregon in 2020, only 3 were referred for a psychiatric or psychological evaluation. So why do we need to expand the list of who can be a counselor in this issue? I don't know. I tend to think it's because they want to open assisted suicide clinics, okay? And if you look at independent clinical social workers, advanced social worker, medical health counselor, psychiatric advanced register, you're looking at adding to who can be counselors. Well, they would make it easier to open an assisted suicide clinic. That's what my thinking is, because there's not many referrals already for counseling. They suggested reducing the 15-day waiting period by replacing it with a 72-hour waiting period. And then they said, similar to the Oregon bill, a law, that if the person is going to die in less than 72 hours, or it appears they're going to die in less than 72 hours, they can waive the waiting period completely, same-day death. Now let's think about this. If someone's going to die in less than 72 hours, why do we need to kill them? Like, what's the need? What's the point? Why can't we just let them die a natural death? Like, this is the kind of thing that starts making you wonder, what is this all about? I mentioned here about the studies. If you look on your Google and you Google will to live studies, there's significant studies that have been done on the will to live, and you realize that the will to live of a human person fluctuates over time. A person's bad day becomes their last day with this type of legislation. Now, the Washington State bill has not passed. It passed, I believe, in the House or Senate. Anyway, it has not passed both houses. So it will come back in 2022. In the final paragraph of the 2020 Assisted Suicide Report in Hawaii, the Department of Health recommended the following changes to the assisted suicide law. My first question is, why does the Department of Health in Hawaii think they have to advise the government to liberalize or make the law, take out some of the safeguards in the law? Why do they think that's their role? I don't know why they would think that's their role. Anyway, they wanted to waive the waiting periods if the attending provider or consulting provider agree that the patient's death is likely going to be prior to the end of the waiting period. So once again, if someone's near to death, we can waive the waiting period because that allows us to give them assisted suicide. If they're that close to death, just let them die. Take care of them, take care of their pain and symptom management. You don't have to kill them. Like, this is craziness. Just to give you a story, in Canada, there was a big controversy in Winnipeg. Now, Winnipeg's a pretty cold city. We call it Winterpeg often. But anyway, the fact of it is it's in Winnipeg, and it's a fairly large city, Winnipeg. There was a big controversy because somebody had asked for euthanasia, but they were at a Catholic hospital. So they were told they couldn't have euthanasia because they were at a Catholic hospital. But the Catholic hospital did agree to transfer them to the public hospital. That person, while being transferred to the public hospital, died. And then there was this big push in the newspapers. Well, isn't this terrible? That person was denied their right to die. Now think about this. They died on their way to the public hospital. No one killed them. They died on their way to the public hospital so they could get euthanasia. But because they died before they got euthanasia, they were denied their right to die. I think that's pretty insane myself. Nothing personal. Maybe I'm not too entertaining right now, but I think it's pretty insane. But this is the kind of mentality we get. Given access to healthcare providers is also, they are looking at in Hawaii, they're saying, well, they need to have access to healthcare providers because it's limited. Now, here's the thing. They want to expand who can also do it in Hawaii. And the reason is, in Hawaii, there's certain parts of Hawaii where there's no assisted suicide because there's no one willing to do it. If there's no one willing to do it, then there's no assisted suicide, right? The existing approval of, let's be honest here. The existing approval and reporting system in assisted suicide laws in the US, they already deny effective oversight of the law. There is no effective oversight of the law. The law already allows the same physician to approve assisted suicide, to be the same one then who prescribes assisted suicide, and then to be the same one who's required to report the assisted suicide. So what do you have? You have a self-reporting system. And in a self-reporting system, what does it mean? It means it protects the physician, a self-reporting system, because a physician is the one who is self-reporting their acts. So if something seems controversial, or there's a bit of gray area in their decision, obviously speaking, they're not going to report the gray area. It's just that simple. The system is designed in order to protect the person who's participating in the act. And it makes a lot of sense if you think about it. Doctors are not people who are wanting risk. So if a physician decides that they're going to do assisted suicide, the last thing they want is to have a family sue them or to have possible problems because they caused someone's death. And the law provides them total oversight, just so you know. The self-reporting system opens the door. Now they want to open the door to lesser trained, qualified medical practitioners to self-report. So New Mexico, we're going to go through this fairly quickly. I've already gone through what Washington was talking about. So the New Mexico bill actually did have within it this wider group of people who could participate. So it's not limited to physicians. You can have licensed physician assistants, osteopathic physicians, nurses registered in advanced practice. They can all be involved with assisted suicide. They also expanded the list. And the reason, as I say, they expanded the list of who can participate is that allows for more assisted suicide, because obviously it eliminates the problem of too few people willing to do the act, right? The law expanded the list of also who can counsel. I don't know why that's necessary. I really don't. They send almost no one to counseling anyway. So why do you need a list of expanded for counseling? The only reason, again, I think they're doing this is that allow for an easier setting up of an assisted suicide clinic. Now, what New Mexico did, which was even more concerning, on top of it is Section 3G of the law, waives the requirement that a person be confirmed by a second healthcare provider if that person's enrolled into hospice. So let's be brutally honest. Being enrolled in hospice and actually receiving care in hospice can be two very different things. Lots of people are enrolled in hospice, especially since the assisted suicide lobby has always pushed that if you ask for assisted suicide, then you should also be enrolled in hospice. So you see the numbers in Oregon, it says 90-something% of those who died by assisted suicide were enrolled into hospice. Does that mean they were receiving any hospice care? I don't know. I have no idea. All I know is the assisted suicide lobby wants that, so it looks like everything's fine and dandy. If they're enrolled in hospice, well, everything must be fine, right? The law only required a 48-hour waiting period, but that could be waived if the healthcare provider believed that the person may be imminently dying. Once again, if someone's that close to death, why do we have to kill them? Let them die. Let them die naturally. Keep them comfortable. Let them die. We're not opposed to death. We're opposed to killing. Therefore, the law allows for a same-day death. Studies, I've already talked about. Clearly, New Mexico's assisted suicide represents future expanded assisted suicide laws that we will see being pushed in the U.S. There's no question about it. The New Mexico law is going to become the template for other laws that we'll be seeing being pushed in the U.S. Now, how do we fight assisted suicide? Now, Sarah can jump in at any time. I say first, we need to call it what it is. A lot of people, we like to talk about these things. We talk about euphemisms. You hear it in the media, aid in dying. We talk about different things like physician-assisted death. And these are all terms that make us feel better. We need to tell people what it is. What is it? We oppose assisted suicide not because we're opposed to dying, but because these laws allow one person, usually a physician, but as you see in New Mexico, it could be a registered nurse, to be directly involved with causing the death of another person. Any law that allows someone else to be involved with killing me is a bad idea. Thank you very much. You're assuming too much in the law if you're assuming that someone else should have the right to kill me. Creating exceptions to homicide, now that would of course be euthanasia, lethal injection. That's what we've done in Canada. That's what California would be doing if the Shavelson case gets through. or creating exceptions to manslaughter or assisting a suicide. These are bad ideas, very bad ideas. These are bad public policies. The term aid in dying, you need to know, is used for both euthanasia and assisted suicide. So throughout the US, you're seeing them use this term aid in dying because they know it's a softer term. They know that it's a term that people are less opposed to. When they do polling, they find a much stronger support for aid in dying than they do for support for assisted suicide. So they use the term aid in dying. But the aid in dying term is used for both euthanasia and assisted suicide. So they're getting ready for the flip over in the US.
Now, one
Yep.
thing you can say if you're having a discussion with someone or they're saying that don't call it assisted suicide because it's not suicide. It's different when somebody who is ill and elderly wants to kill themselves than anybody else. And so one thing you can say is, well, doesn't that law that you're proposing create an exception to the criminal statute that punishes assisting a suicide? Because it does.
So just so you know, there's quite a few questions also into the chat, and we will take them in 1 minute. We're almost done our presentation. And just so you know, if anybody wants the PowerPoint, I can send it to them. You can easily email me, and my email will be at the end of the presentation. Assisted suicide is sold as an autonomous act, my body, my choice. Has anybody ever heard that term before, my body, my choice? I don't know. You might have heard that somewhere else before. But this is a lie, okay? Assisted suicide is not about an autonomous act. That's how it's sold. It's the flag they wave. It's my freedom, right? That's how they sell it. But since it requires a direct involvement of a physician or a nurse, etc., to provide and to approve and then provide a lethal drug cocktail, this is not about autonomy per se. This is about the act of another and the approval of another. Many of the people requesting assisted suicide also have issues related to capacity. Like, this is not true autonomy when you're looking at people who are often experiencing hopelessness, despair, alienation. Often they have cognitive dissonance or cognitive issues because they're experiencing significant health conditions which is affecting their thought processes. So this is not autonomy as we would normally refer to it as. Assisted suicide is more about abandonment than it is about autonomy. We need to talk about what it is. The other side claims that these are deaths with dignity. They're going to sell death with dignity, death with dignity. They describe them as peaceful, quick, and painless. Yeah.
And,
we know that many of these deaths are not necessarily peaceful, not necessarily quick, and not necessarily painless. We believe in caring for people, not killing them. We need to talk about these lethal drug experiments. People are silent about it. The other side is, waving the victory flag. Look, we've improved. It's the time of death is not averaging, 8 hours anymore. It's down to 6 hours. And this is kind of thing. Oh yes, and now it's cheap. We can give you cheap drugs to kill you. Give me a break. Death by lethal drugs may not be dignified. It may not be quick, and it may not be peaceful. I've written a lot about it, and I always provide links to it. If you want these articles, I can send you these articles, and there's always links to the original article. These experiments were inappropriate, very likely unethical, and certainly caused people to suffer. Nuremberg ethics clearly prohibit human experimentation without proper consent. They had certainly consent to prescribe the lethal drugs, but they did not have consent for human experimentation. We should not focus on palliative care. This is very controversial, but it's not if you think about it. I'm not saying we don't want palliative care and good palliative care. What I'm saying is by focusing on palliative care, we're not actually creating a political advantage. Okay, why am I saying that? The assisted suicide advocates also support palliative care. They just don't have a problem with killing. So if you say, well, I'm opposed to assisted suicide, I support palliative care. Well, that's fine. The other people will say, I support assisted suicide and I support palliative care. So, you've not created a political difference. Now, you know that we believe in caring for people. So obviously we want good care, proper care at the end of life. There's no question about that. Focusing on palliative care also causes a problem for us politically. Why? Because if we're focusing on pain and symptom management, and the reason people are asking for assisted suicide is they're trying to avoid pain. Now you can say, oh, we can manage it. And they'll say, well, what about that 1% or that 2%? They're actually not interested in the 1 or 2%. That's just the argument they're using to undercut your argument. But they will use that argument successfully. We have to focus on what assisted suicide is and why it's not necessary. We have to focus on what it is, okay? We need to work with people from all political points of view. For instance, the disability folks tend to be politically different than people in the pro-life movement, and that's fine. It's good to have different political points of view opposing assisted suicide. There might be people coming from a medical background, and there might be people who are coming from a suicide prevention background. There might be people coming from just an average friendly whatever point of view, and all of that is perfectly good. Okay, there's no silver bullet to stopping assisted suicide laws. It's about working together in coalition. That's what it's about, okay? There's no silver bullet of one argument that just simply worked for everybody. Oh, there it goes. By avoiding certain arguments, you avoid also certain supporters who might help you. People with disabilities have personal experience. This is very important about them. The other side's selling stories also. They talk about these sad, terrible stories. People with disabilities have stories about why assisted suicide is wrong. We need to work closely with them. We need to encourage people to work together. We must never discourage people from working on their own or working together. Don't hesitate to talk about Canada. I'm sorry, but Canada is a terrible place what's happened with our laws. It's absolutely insane where we've gone in a very quick way in Canada. Canada legalized euthanasia and assisted suicide in June of 2016, which we like to call MAID, because MAID makes us feel better. You know, medical aid in dying. Doesn't that make you feel better? Anyway, in less than 5 years, we expanded the law already, and it includes people who have mental illness. It includes, we took out our waiting periods. It's absolutely insane how fast Canada has gone. And the latest Canadian data showed that there was a 34% increase in 2020 alone in euthanasia deaths. And it's now being interpreted as healthcare. Healthcare. When did killing become healthcare? Like the Netherlands and Belgium, Canada's talking about expanding euthanasia for children, for incompetent people, for people with Alzheimer's, dementia, and we've already added it for people with mental illness. And they're talking about further expansions. It's been insane, okay? It's okay to talk about Canada. I don't mind you saying how terrible things are in Canada. My prime minister does have nice hair, but that's about it. Trampling on conscience rights. Well, look at this. Conscience rights are an issue in the US. Look at what's happening in Canada. The BC government, British Columbia government, defunded the Delta Hospice Society in February of 2021. Why? Because they refused to kill their patients by euthanasia. So because the Delta Hospice Society refused to kill people, they were defunded. They lost their funding. Ontario doctors are being forced to provide an effective referral for euthanasia. What's an effective referral? It's not just a referral, it's a referral for the purpose of the act. So they're being forced to refer their patients to the killer. And there's my information.
I think it's part of devaluing certain people. If they are disabled, if they are elderly, if they're seen as not being very useful, not contributing much to society, a drain on society, a drain on our healthcare system, then let's encourage them to take the early out. And get
Someone
rid
says,
of them.
yes, there's a big push. I think also it has to, there's a philosophical point of view for a lot of people because it's motivated by fear. They are in fear of a bad death. They're in fear of you know, having pain and suffering. But of course, what's wrong here right off the bat is they are causing death. So what we're doing is we're allowing someone to kill you in this situation.
Thank you, Sarah and Alex, for a wonderful disposition or exposition of all these issues. The only thing I was going to say, I posted for the chat some of the more common euphemisms and the fact that all social engineering is driven by verbal engineering. And so that's a critical issue that you made, Alex, earlier. The other thing is, I think the whole concept of radical autonomy is adding to Sarah's list of why is this happening, and the delusion of control that you can control all events in your life, and of course the uselessness of suffering by utilitarian, essentially agnostics of any sort of transcendent worth for lives when there's actual suffering involved.
Yeah, and
Yes.
it's beyond them to think that elderly people can still have friendships and relationships and enjoy being together with other people, even if they can't go skateboarding or whatever.
So I want to inform everyone that Dr. Toffler, who just spoke a second ago, did a Zoom meeting with us quite a few months ago, but it was really amazing on how assisted suicide, how these drugs work. That wasn't his only focus, but that was one of the focuses. And the whole thing about the assisted suicide experimental drugs and what they've done and what's happening. And I think it was very important because it really undercut the concept of the assisted suicide lobby, saying that this is all about care and dignity and dying, and that they're only concerned about providing people with a good death, etc., which of course was a total lie. So if you're interested, you can email me for that also, or you can go to our YouTube page, put in Euthanasia Prevention Coalition, and you'll see that that's one of the videos in there. Definitely worth watching, definitely very powerful. So it's 3 o'clock now. So what's going to happen is that we're—
I just want to quickly mention that Dr.
Absolutely, Sarah.
Toffler is on the board of the Euthanasia Prevention Coalition USA, and we greatly appreciate his participation.
And Dr. Toffler is also involved heavily in a group called Physicians for Compassionate Care, and you can look that up. They have an excellent website with information. But Physicians for Compassionate Care we have been heavily involved not only in Oregon, even though they have mainly an Oregon base, but they're right across the U.S. with opposing these assisted suicide laws. So we're very thankful. Isolation, loneliness, feelings of my life lacks value, purpose, meaning. As someone is nearing at the end of their life, these are normal human feelings. People going through end of life or certain health conditions often feel that way, that their life has lost meaning or value or purpose. And so then assisted suicide then becomes problematic because they're seeking it, not because they're seeking, an end to pain and suffering, or etc., because they become so emotionally and mentally distraught. Even the suggestion then of assisted suicide or euthanasia becomes a problem. I can tell you several stories about that, but we are finished now, and we're happy. As I said, we will share this video with you in a couple of days. And if you ask us questions at info@epcc.ca or send requests, I'm happy to deal with it. Thank you very much.